me know. Am I audible? Am I audible? Let me check. Am I audible? Okay, let us start. Hello everyone, welcome to Unacademy Future Doctors. I myself, Dr. Dipti Kariya, I'm MD PhD Physiology and I'm educating MBBS, nursing and physiotherapy students. I have more than 17 years of teaching experience. Within few minutes, let me explain about our subscription. So in our Unacademy, we have Plus subscription. Here you can choose the best from the best. Here you can access both live as well as recorded classes. You can study on the device of your choice. You can learn from India's top educators for your medical exams. You can access question bank, which is having more than 25,000 questions. You can compete in the live test as well as quizzes. And within 12 months, we are coming with our printed notes. Another subscription is iconic subscription. In our iconic subscription, your access to the best from two of the best. Now, which are these two? One that is Unacademy and Prep Ladder with Unacademy, and second one that is Unacademy and Prep Ladder with Prep Ladder. So in first one, features are you'll be having well structured live batches. You can have recorded classes which covers the full syllabus. You can have question bank which is having more than 25,000 questions. You can complete live tests as well as quizzes, and you can have comprehensive and printed as well as digital notes. And in second subscription, that is Unacademy and Prep Ladder, with Prep Ladder, you have clinical and integrated essentials, video lectures from the Dream Team. You can have Question Bank 3 with active guidance, system tags, and much more. Rapid revision, snapshots, treasures, and 2021 Dream Notes. So you can subscribe from your mobile, either Plus or Iconic subscription, and you can use my code Dipti10 to get 10% extra discount. Okay, and longer the duration of subscription, cheaper are the rates. So if you are in first year or second MBBS, you can go for longer subscription. Okay, so you will be having all benefits of the subscription. It is like your whole syllabus will be completed. Okay, now, so today's topic, that is lung volume and capacities. One of the important topic may be asked as a short note. From this topic, so many small short notes will be asked, that is like FRC, okay, or timed vital capacity, one of the very important questions from today's topic, okay, or maybe FEV1, FEV2, okay, FVC. This is timed vital capacity. So all these questions may be asked from today's topic. We will discuss now. So lung volumes and capacities, they are measured by spirometer. You must have seen this kind of instrument in your physiology laboratory, okay, and this spirometry, that is important lung function test. Here what we are doing is we are measuring lung volumes and capacities. Okay, students, they have so many questions regarding this time vital capacity, FRC, how to measure this, what is the clinical significance, all we will discuss in today's video, so please watch the video till end. Okay, now, so here you can see this is a spirometer which we are using in the laboratory. Nowadays, computerized spirometer is also available. This is computerized spirometer. Okay, now, so first of all, we will discuss about static lung volumes and capacities. So first, we can divide this capacities and volumes in static and dynamic. And so in static lung volumes, what is the meaning of static? Here there is no time factor. Time factor is not used. Means we are not concerned with time. We are just concerned with the volume. Okay, in how many seconds, minutes, we are not concerned. Okay, starting with first one, tidal volume. What is this tidal volume? You can see here, tidal volume is the volume of air inspired or expired with normal breathing. You can see here, normal breathing, amount of air inspired or expired. Okay, it is about 500 ml. About means not fixed. This value is from your standard textbook. In some of the book they have written 350 to 500, 350 to 600 ml. In standard textbook guidance they have given this value. Second, that is expiratory reserve volume. Sorry, second, that is inspiratory reserve volume. This one. What is this inspiratory reserve volume? You can see here. Above tidal volume, this is tidal volume. Above tidal volume, extra volume of air which is inspired over and above normal tidal volume. That is your inspiratory reserve volume. Okay. Now, this normal value of inspiratory reserve volume is about 3000 ml. About. It may vary according to age, according to gender, according to body size. Okay. Next is ERV, expiratory reserve volume. What is it? It is the extra volume of air. Here, very important thing is you need not to consider tidal volume. Over and above, extra volume of air that can be expired over and above tidal volume. This is expiratory reserve volume. Normal value is about 1100 ml. Okay, 1100 ml. Okay, then next is residual volume. You can see here this one. Residual, the name itself suggests, which is remaining, left over. It is the volume of air remains inside the lungs after forceful expiration. Suppose you are expiring forcefully, you are trying to expire the whole air in the lungs, but still small amount of air is present in the lungs, and that is your residual volume. Normal value of residual volume is about 1200 ml in the lungs in adult male. Okay, now, so this is about lung volumes. Next is lung capacities. Now, what is capacity? Capacity means when we are adding two or more lung volumes. Okay, suppose inspiratory capacity. So inspiratory capacity is equal to tidal volume plus IRV. You can see here, this is inspiratory capacity. So how to define this inspiratory capacity? Maximum volume of air inspired after tidal expiration. Very important thing here is starting with expiration. Then only your tidal volume is added and IRV is added. So definition of inspiratory capacity is maximum volume of air inspired after normal tidal expiration. We are starting from here, expiration. Value is tidal volume is 500 ml, IRV is 3000 ml. So the value is 3500 ml. Okay. Then expiratory capacity here. This one, expiratory reserve volume plus tidal volume, this one. This. So expiratory capacity is equal to ERV plus tidal volume. Definition: it is the maximum volume of air that is expired after tidal inspiration. You have to add here, starting from tidal inspiration to the expiration. Okay. Normal value is tidal volume plus ERV. So tidal volume is your 500 ml, ERV is 1100 ml. So this value is 1600 ml. Okay. Then next is FRC, very important capacity, functional residual capacity. So here you can see FRC is equal to ERV plus RV. Expiratory reserve volume, this one, plus residual volume, this one. Okay. So here, what is this FRC? It is the volume of air remains inside the lung after normal expiration. You can see here, this is normal inspiration, this is normal expiration. And after normal expiration, this much volume is left in the lung is your FRC. Very important thing. So FRC, how to calculate? ERV plus RV. ERV is 1100 ml and RV is 1200 ml. So your FRC would be 2300 ml. Now, very important thing here is, by this pyrometer, we cannot measure FRC. Why? Because this residual volume is not coming out. This one. So how can we measure? Because it is not expired. So how can we measure? For the measurement of FRC, we have indirect methods. A very important thing, this may be asked as a short note. FRC and measurement. There are two methods. Try to remember. Number one, that is open circuit method, which is also known as nitrogen washout method. Second one, that is closed circuit method, which is also known as helium dilution method. Try to remember. We will discuss calculation. We will discuss calculation in easy way. Okay. Now, what is this open circuit method or nitrogen washout method? Now, what you have to do in this method? Ask the subject to inspire pure oxygen for 5 to 7 minutes. Why 5 to 7 minutes? Because in this 5 to 7 minutes, your whole FRC comes out. Okay? Because it requires 5 to 7 minutes to bring the FRC out. So, what is the procedure? Ask the subject to take pure oxygen. Okay? Inspire pure oxygen and expire in the spirometer, which is not having nitrogen. Why? Because we are just trying to find out nitrogen coming from our FRC. So our spirometer must not have nitrogen. Okay. So now what happens in this 5 to 7 minute, nitrogen is coming out from our lungs, from our FRC. Okay. Now, so what happens? Now we will discuss about calculation. So suppose if you have inspired from oxygen and expired in the spirometer. Okay. In 5 to 7 minutes, suppose you have expired 40 liters of air. How this 40 liters comes? As I told you, pulmonary ventilation, or in 1 minute ventilation, that is equal to respiratory rate multiplied by tidal volume. Respiratory rate is your suppose 12 per minute. Tidal volume is 500. So how much? 6000 ml per minute. So in 5 to 7 minutes, this is 7 multiplied by 7. So it becomes 42,000 ml. So in 5 to 7 minutes, we have expired 40 liters. Okay. Now from this 40 liter, you just take a sample of 100 ml and measure how much nitrogen is there in this 100 ml. So suppose you have 5 ml nitrogen, 5% or 5 ml. Okay. So in 100 ml sample, nitrogen is 5 ml. So in 40,000 ml, how much nitrogen? That is 40,000 multiplied by 5 divided by 100. And your value is 2000 ml. So your FRC contains 2000 ml nitrogen. Okay. Now, important thing comes here. This nitrogen is only 80% of air. Because in your lungs, you don't have only nitrogen. You have small amount of oxygen, small amount of other gases also. Okay, so how to calculate? For example, suppose 80% is nitrogen, so 80 ml of nitrogen in 100 ml air. Okay, so 2000 ml nitrogen in how much? For example, suppose if I say that I secure 80% marks, and somebody says that I secure 2000 marks. So 2000 from how much total? So here you can get the total value of FRC, because only 80% value we get, that is 2000 ml. So 80% is 2000 ml, 100% is how much? And that is your 2500 ml, that is your FRC. So this is the calculation, very important. Sometimes it is not given or not understood by reading any of the book. Okay, so this is your calculation for measurement of FRC by which method? Open circuit method, nitrogen washout method. Second method is closed circuit method or helium dilution method. What we do here is, this is closed circuit, means the person has to inspire and expire in a same spirometer. This spirometer contains known amount of helium. So suppose helium concentration is, for example, 10 liters. So person knows that this much of helium is present in the spirometer. So breathing from the gas mixture having helium. Okay, now and breathing for 8 to 10 minutes. So your whole FRC get mixed with this spirometer volume gas. Okay. Now, what is the calculation here? You can see V1 C1 is equal to V2 C2. V1 means initial volume in the spirometer. C1 this initial concentration of helium. V2 is final volume of spirometer and C2 is final concentration. So here important thing is, when we are considering about final volume is equal to, because this is closed circuit, so air is not going out. Whatever air added, that is the air from FRC. So what we can do is, instead of V2, we can write down V1 plus FRC. Okay. So now again mathematical calculation for this is V1 C1 is equal to V1 C2 plus FRC C2. So we want to find out FRC. So how can we get the FRC? FRC C2 is equal to V1 C1 minus V1 C2. This will be going this side. Okay. And FRC is equal to V1 C1 minus V1 C2 divided by C2. So this is the formula by which you can get the FRC. How you can see? Suppose if you know initial volume of spirometer, you have filled the spirometer with around 100 liters of gas. Okay, volume we are knowing, concentration of helium we are knowing, suppose 10 liter or 20 liter. Then we are knowing final concentration of helium from 10 liters, suppose it has become 5 liters. Okay, and final concentration of, if suppose we are knowing, so from all this way we can get FRC. So this is the method for calculation of FRC. These two are indirect method. One is open circuit method and second, that is closed circuit method or helium dilution method. Now, why FRC is important? Why this volume of air should be there in our lungs? Because you can see here about 2 liters, 2300 ml of air is present in our lungs. So what happens? Because this air is there, our lungs will not collapse. Otherwise, what happens when we expire? All the air comes out and the lungs, they collapse. So that is one advantage, very important. Second thing is, when we are expiring, at that time also gas exchange is continuous. Inspiration and expiration is cyclic processes, but gas exchange is continuous. So small amount of, or you can say 2 liters of air is there, that will help in gas exchange. Okay. Third advantage is, suppose if I tell you to hold the breath, so breath holding is possible because 2 liters of air is there inside for gas exchange. And fourth, very important advantage, that is dilution of toxic gases. Suppose if you have inhaled some toxic gas, but our inhalation only contains 500 ml of gas and we have 2 liters inside. So this 500 ml gets diluted in this 2 liters. So toxic gas gets diluted. So these are the advantages of FRC and RV. Now, which are the factors they affect FRC and RV? Various conditions in which FRC is increased, like in old age, because the person cannot expire. Less expiration, more the air inside. When there is emphysema, then also large amount of air is there. Obstruction, like in bronchial asthma, person is having obstruction, that is chronic obstructive disease. In those conditions also FRC is increased. Okay, very important capacity now we come, that is vital capacity. What is vital capacity? Here this is vital capacity. It includes all tidal volume, IRV and ERV. How to define it? It is the maximum amount of air which is expired after deepest inspiration. Very important, how to get vital capacity. Ask the subject to inspire maximally, inspiration completely, and expiration also forcefully. Deepest possible inspiration, deepest possible expiration. So what happens? Suppose when person is inspiring, here the lungs are filled with this much of air, and when the person is expiring, this we are measuring, this is vital capacity. So IRV comes first, then tidal volume, then ERV. So this is your vital capacity, this one. Okay. Now, value is tidal volume, we all know 500 ml, IRV 3000 ml, and ERV that is 1100 ml. So total will be 4600 ml. Okay. Now, which are the factors they affect vital capacity? Some factors are physiological, some are pathological. Physiological important factor is chest thoracic cavity size. Suppose size is more, definitely vital capacity will be more. So all these capacities are more in males because thoracic cavity size is more. 20 to 25% more in males as compared to female. This is physiological, completely physiological. Age. When the age increases, elasticity decreases. And elasticity decreases, elastic tissue is less, definitely vital capacity is reduced. Strength of respiratory muscle. When the muscle strength is more, vital capacity is definitely more. So therefore, vital capacity is more in swimmers, divers, not driver. Divers means those who are diving in the deep sea. Their respiratory muscle strength is more. Okay, height increases, definitely vital capacity increases because size increases. Okay, posture also important factor. Whenever we are in the lying down position, vital capacity is less. Okay, vital capacity is more in the standing position. Why? Because diaphragm descends down. And next thing is, when we are standing, our venous return is less venous return, so less volume is occupied by blood and more volume is provided, more suction is provided, so increase in the vital capacity. Okay, pregnancy, vital capacity decreases because diaphragm is pushed up because of the fetus. Okay, then pathological, these all are physiological factors. Which are physiological factors? We have discussed age, gender, strength of respiratory muscle, posture, and pregnancy. Okay. Pathological factors are ascites. What is ascites? Accumulation of fluid in the abdominal cavity. Same thing here. When the fluid is accumulated here in the abdominal cavity, what happens? Diaphragm ascends up and all these capacities, they decrease. Pulmonary diseases. When there is disease in lungs, definitely expansion capacity of the lung decreases and therefore vital capacity decreases. Most of the lung disease like pulmonary fibrosis, emphysema, pulmonary edema, pulmonary effusion, obstruction, pneumothorax, in all these diseases, vital capacity decreases. Okay. Last capacity, total lung capacity, last static capacity. Total lung capacity is equal to vital capacity plus residual volume. Very important thing here. We cannot measure this also. Whenever residual volume comes in any of the capacity, we cannot measure it because this is the volume which is not coming out anyways. So total lung capacity is equal to vital capacity plus this one, residual volume. You can see here, this is total lung capacity. Okay. So definition, it is the volume of air present in the lungs. It is not coming out after maximum inspiration. Suppose if I tell you to inspire maximally, How much amount of air is there inside the lungs? That is total lung capacity. And this is equal to vital capacity is 4600 ml plus residual volume is 1200 ml. So your total lung capacity is 5800 ml. Okay. Now, so this is all about static lung volumes and capacities. Now we come to very important topic, that is dynamic lung volumes and capacity. Now what is this dynamic lung volumes and capacity? Dynamic means here time factor is there. You can see here time seconds. Hmm? So what is this timed vital capacity or forced vital capacity? Here, it is the volume of air which is expired, same definition as vital capacity. Initial definition is same, that is volume of air which is expired rapidly with maximum force after maximum inspiration. Okay, but here one word is added, that is rapidly. Okay, so because time is the factor. Okay, so definition is volume of air which is expired here rapidly with maximum effort after maximum inspiration here. Okay, this word rapidly is not there. Just give me a minute, my laptop is running down. Just give me 1 minute, just a minute. Really sorry the interruption. Didn't pen now. So let us continue. So let us continue with important topic, that is dynamic lung volumes and capacities. Okay, so let me explain again, that is timed vital capacity or forced vital capacity. Definition is volume of air that is expired here rapidly with maximum force after maximum inspiration. Here, as I told you, rapidly word is important. Okay, now this FVC has three components. Which are this? Number one is FEV1, second is FEV2, and third is FEV3. Now, what is this FEV1, V2, and V3? So, FEV1 is, you can see, suppose, let me explain first. FVC, this one. FVC is expired, this one. Suppose your vital capacity is 4600 ml, okay, from which 80% of it is expired in first second. Okay, 80% is expired in first second. So 80% of FVC is FEV1. Let me explain. 4600, how much is 80% of 4600 ml? 4600 ml, 4600 ml. So 80%, that is around 3400 ml. So it must be expired in 4 seconds. Okay. Then next come FeV2. FeV2 means percentage of FVC which is expired in first 2 seconds. Very important thing here. You have to start from 0 to 2. This one. It is 90 to 95% of FVC. 90 to 95, 90% means 90% of this 4600. 4600 multiplied by 90%. Okay, that is your FeV2, percentage of FVC expired in first 2 seconds. FVV3 is percentage of FVC expired in first 3 seconds. So mostly 98 to 100% whole 4600 ml must be expired in this 3 seconds. So this is the meaning of FEV1, FEV2 and FEV3. Okay. Now, what is the clinical significance? Very important thing here is we can differentiate restrictive disease from the obstructive disease by this FEV1 and FVC. How? You can see here. This is normal person. You can see FVC here. This one. This is the FEV1. Okay. Now, so this is, you can see V1, that is 80%. But what happens in obstructive disease? Because of obstruction, person cannot expire total FVC. Okay, so FVC is not been expired, from which FEV1 is reduced markedly. So in person with F or with obstructive disease, there is marked reduction in FEV1. You can see here. Only it has become 40% instead of 80% here. Okay. So this is for obstructive disease. Now I'm discussing about restrictive disease. Now what happens in restrictive disease? Like in pulmonary fibrosis. Suppose in pulmonary fibrosis, lung volume decreases. Instead of 4 liters, the volume becomes 2 liters only. Okay. So your FVC is 2 liters only, from which 80% is expired in first second. So FEV1 is 1.6 liters. So your value is 80%. But total FVC is reduced. Okay. What happens in obstructive disease? FEV1 is decreased, whereas in restrictive disease, FVC is reduced. Okay. So by this graph, you can easily determine whether the person is having obstructive disease or restrictive disease. I'll show you algorithm also. Suppose you can see here, this is the person having FVC. FVC, you can see 80, more than 80% means it is around normal. Along with that, if FEV1 is also more than 80%, then you can say the person is having normal lung function. Normal PFT means pulmonary function test. Okay. Then comes second thing. Here suppose FVC is more than 80%, but FEV1 is reduced. As I told you, whenever there is decrease in FEV1, definitely the pattern is obstructive type. Because obstruction, person cannot expire in first second. Person will expire, but not fast, not rapidly. Okay. Then next case is, suppose FVC itself is reduced. Okay. FVC is reduced. That is the pattern of restriction. But FEV1 is more than 80%, as I told you. FVC, suppose it becomes 2 liters instead of 4 liters. And FEV1 is 1.6 liters. So this will be 80%. So this is restrictive pattern. And last one, both are reduced. FVC is also reduced and FEV1 is also reduced. Then the pattern is combined. Obstruction as well as restriction. Okay. So by this algorithm, you can easily understand what is obstructive pattern, what is restrictive. Just let me explain again. If suppose your FVC is normal, but FEV1 is reduced, then obstructive pattern. FVC is reduced and FEV1 is normal, then restrictive pattern. And if both are reduced, then combined pattern. Okay. So this here again you can see this is normal, this is obstructive, and this is restrictive. Okay. Next parameter, that is FEF 25 to 75%. You can see here this is 75%, here is the 25%. So this is also, the full form is forced expiratory flow rate, means rate of the air flowing in this part between 25 to 75% of expiration. Why this is to be taken? This is also known as maximum mid expiratory flow rate, because when we are expiring in the middle part of the expiration, our flow rate is maximum. Why? Because initially some of the this bronchi, they are deflated, so they require time to get open, and in last also there is a less airflow. So this one middle one is maximum. What is normal value for this FEF? 25 to 75%. Normal value is 300 liters per minute. This is not showing that we are inspiring 300 liters. This is the velocity, rate of the flow, 300 liters per minute. And time required is 0.5 seconds. Okay. And this is sensitive indicator for small airway disease. If there is small airway disease, then we have reduction in this FEF 25 to 75%. Same way other indicator is FEF 200 to 1200 ml. Post expiratory flow rate between 200 to 1200 ml of air. This is also middle part of the flow rate. Then next terminology is respiratory minute volume, means in 1 minute how much volume of air that is inspired and expired. As I told you, tidal volume multiplied by respiratory rate, and that would be 6000 ml per minute. This is per minute. Okay. Next is maximum voluntary ventilation. This is different from respiratory minute volume. Here, ask the subject to inspire and expire maximally for 15 seconds or 12 seconds. Okay. And multiply this 12 with the 5. So you will get for 60 seconds. Okay. So this volume or maximum volume of air which is taken in or out in 1 minute we are getting. Normal value, that is 90 to 170 liters, or average is 100 liters per minute. And it is reduced in the patient with respiratory disease like emphysema, airway obstruction, respiratory muscle strength reduction, and all. Then next is breathing reserve. What is breathing reserve? It is the difference between maximum voluntary ventilation and respiratory minute volume. Suppose your maximum value of ventilation, that is, hello, Aadhar, watching from Nepal. Thank you. So maximum voluntary ventilation, suppose your value is 100 liters and your respiratory minute volume is 6 liters as we have discussed. So what would be your breathing reserve? 94 liters. Okay, this is the value. Now, next one is dyspnea index. This dyspnea index is percentage of pulmonary reserve. Means maximum voluntary ventilation minus respiratory minute volume divided by maximum voluntary ventilation into 100. Simply saying, suppose my maximum voluntary ventilation is 110 ml and my breathing reserve is suppose 97. So somebody else is having maximum voluntary ventilation 100, breathing reserve is 90. So how can I say that whose breathing reserve is good? So for that, what we do is we are calculating in percentage. So you can see here, maximum voluntary ventilation, suppose my maximum voluntary ventilation is 100, breathing reserve is 97. So what if my maximum voluntary ventilation is 100? This is percentage. Okay. Suppose somebody's maximum voluntary ventilation is 112 and the breathing reserve is 98. So how can we compare these two? For that we require percentage. How much from 100? So 97 multiplied by 100 divided by 110. This is the formula which we brought here. Maximum voluntary ventilation minus pulmonary ventilation multiplied by 100 divided by maximum voluntary ventilation. So this is your dyspnea index. So this is all about today's topic. These are the questions maybe asked from today's topic. You can write down also, define the process of spirometry and draw a label diagram of spirometry. Lung volumes and capacities. One of the important question, draw a diagram of lung volumes and capacities and label it. Functional residual capacity, vital capacity, timed vital capacity, clinical significance of timed vital capacity, and FEV1. So these are all the questions. Thank you all. If you like my video, you can like, share, and you can subscribe our channel. Thank you.